There we go. All right. Now, we'll review a lot of the pathophysiology of withdrawal as it affects clinical patient care. So that will be heard when we talk about alcoholism, as I finish this quick review of Monday's material. So again, I didn't have you memorize the information in Table 36-3, signs and symptoms of withdrawal from the chapter, because it's really not as hard as that table makes it look. If you take the information from the toxidromes that you learned in the toxicology module, look at all of those effects you get in overdose, and look at what the opposite of those effects would be. That's very, very close to what you get in withdrawal. There are some unique aspects of withdrawal related to opiates, but we'll talk about that on Wednesday. Now again, we will talk about this when we get to alcoholism in a minute after the review, about when we're talking about withdrawal. So today we'll be talking about alcohol withdrawal. What you do when you're talking about withdrawal of any drug is to think which category does it come in. Preventing life-threatening symptoms, or whether you're just maintaining comfort, providing support to get them through the physical symptoms of withdrawal so that you can get to the point where you can manage and getting them into permanent abstinence. So since alcohol is a CNS depressant drug, it has significant abstinence syndrome. It has life-threatening effects, because the CNS depressants do. So that's going to be one of the treatment goals that we'll be reviewing today. Are there any questions about the pathophysiology of dependence, addiction, and withdrawal, or issues regarding the terminology of dependence or addiction from Monday that I didn't answer or that I confused you on? So for the person who's asking about the three main topics of addiction, I'm not sure what you're asking me. From a pathophysiology perspective, what we talked about was the neurotransmitter that's the primary one you need to think about when you're thinking about what causes dependence, what causes psychological effects of withdrawal, what causes the problems with being able to maintain an abstinent state. That would be dopamine being the key one. But all of the neurotransmitters are affected when you're talking about how does dependence develop, how these symptoms of withdrawal develop. So dopamine's the main one, but you have to remember that all of the neurotransmitters eventually get involved, which is why there's like overlap in the dependence and the withdrawal treatment issues that we deal with. And again, the other overarching topics about the pharmacist's role in dependence and issues about managing these patients will come in as we talk about alcoholism and the drug dependence. I wanted to just make a couple of follow-up aspects on the drug screens that we talked about on Monday. And again, the problems with testing drugs, and the problem is when you get aside from alcohol, which clearly has no daily to be in your system, you've got a lot of the drugs that are most commonly involved in substance abuse, for instance, that being the opiates and the benzodiazepines and their sedatives, being abused, but also having a therapeutic rationale to being there. So that creates some problems when we're going to look at screening as far as drug-free workplace policies. For example, Um, and that gets into the reason that gets complicated, separating out drug-free workplace policies and drug screenings, which as pharmacists you have to help people understand, is that what we do and we don't know about qualitative and quantitative testing. So again, just make sure that you understand the difference between a urine drug screen, okay, which uses urine drug screen, which is that rapid test we can do with urine that just shows is it there or not, yes or no. It's really quick, it's not invasive, and it's less expensive. But again, usually what we need to do anything, either clinically for management or for drug abuse testing purposes, is needs quantitative. And so a quick, easy urine drug screen doesn't get it. Okay, so just make sure you understand when I say urine screen, we're always talking about qualitative testing. So those are the rapid, quick, but those are the qualitative ones. And those are the ones that are subject to the false positives. Okay, so there's urine drug screen. Then there is urine drug testing. So when they're talking about drug-free workplace policies, they're usually and impaired driving legislation. They're usually talking about urine drug testing. Now that is where you actually do usually a GC mass spec, no false. So there is a urine drug testing, not screen, but a test, okay? It's also not invasive, like a blood test, and there's no false positives like a screen because you're actually doing gas chromatography, mass spectrophotometry. So if the drug is there, it's there, but it takes days to get back and it's expensive. So since it takes days to get back, it's really expensive. It's not quick. That's why, for example, on the or when we talked about the athletes, they just say we are only going to do the urine drug screen. Therefore, we're going to ban any substance that has a risk of a false positive. Usually when they're talking about zero tolerance policies for jobs where impairment could result in loss of life to yourself or others, they'll usually do urine drug testing, which is quantitative. And again, because we associate a level in urine with a definite association with degree of impairment, they'll do zero tolerance. So high-risk jobs, high-risk employment practices usually have zero tolerance for the quantitative testing. It's because of that impossibility of using a urine quantitative screen and factoring that in with pyramids. Okay. When we're talking about drug screening for the workplace, they're also usually talking about urine screens. The problem with the urine screens in the workplace is that, again, you cannot relate a level with impairment. Okay, and again, think about that. These drugs have a high volume of distribution. They stay in the system for a long time. So a quantitative result still doesn't mean it was used in the recent future. If they've drunk a lot of fluids, they're going to have really dilute urine. The levels are going to be lower. All right. So when we're doing urine drug testing in the workplace, it always has to be looking at a combination of physical signs of impairment and its presence in the urine, just to prove that it even had the possibility on to be on board. Okay, so when we're saying for most jobs, so when they do pre-employment and unannounced screens of workers, they're they're typically doing the more expensive quantitative testing. Okay. And that's because when you get away from using drug testing for clinical purposes, okay, so take yourself back to our toxicology module. When we were talking about drug screens in that setting, we were talking about for the clinical purposes of identifying a drug for management of overdose, which because we can only do we need the quick rapid screening, there isn't anything, so we don't use it much other than specific quantitative testing. Once you get away from using drug screenings and drug testing for clinical management, when you're using anything else, driving, workplace standards, whether the current debate over whether people that get food stamps should have drug screens, you're into the legal realm. Okay, you're into legal issues. So once you're taking it out of the clinical realm and you're dealing with an overdose patient, now you're talking legal. And legal has higher standards. So legal must be, for the most part, quantitative. And that's because qualitative can give you false positives. And anyone who has any legal action taken against them with a simple urine screen, they can always say, oh, it was a false positive. And there's not a leg the other party can stand on with that. There are some extremely rare exceptions, like maybe cocaine in infants. So if we have an infant or a toddler come in and screen positive for cocaine, there really isn't anything that gives you a false positive cocaine value. It shouldn't be cocaine, so then it gets to be a child protective services issue. But even then, without a quantitative value, you don't know when that cocaine got there. And it gets into, oh, well, did it happen when the kid was with the mom yesterday or with the dad today or vice versa? So even in that, you end up really needing a quantitative level. So for the purposes of these screens for drug-free workplace policies, they really need to be quantitative. Now, urine quantitative levels are really tricky. Okay, blood quant levels not tricky. However, with a blood test, it's invasive. So when you go pulling a worker out who you suspect is impaired at the workplace and you require that you stick them with a needle, that raises a whole lot of personal rights issues. Because you are now, that person hasn't been arrested, they don't have any legal action against them at that point, you're making them do something that's invasive. So instead of just peeing in a cup under supervision, which is some privacy issues, so there's workarounds for that. It becomes a legal issue, and blood becomes an invasive personal right issue. But unfortunately, that would be the ideal legal standard. So that's what's making the driving while impaired bills a little tricky, is because they would require the blood test because that's the ideal legal standard. But now you're going to require people to do something against their will, which means those people have to be arrested first. So there's all sorts of legal ramblings. The other issue is that when you start to develop these policies, you have to appreciate that labs have to be, especially do okay, so you can't, your regular hospital lab, when they do testing, that's great for clinical purposes, and it's really accurate for clinical purposes. Those labs do not meet the standard for drug testing employee purposes. So the labs that do the testing for workplace standards have to be specially certified to do that. They have to have special documents showing how many times that machine was standardized, that that machine is accurate, that they know how to do chain of custody. So that's why you guys, when you get into your fourth year, some of your rotations require drug testing. That's why you're limited to where you can go. That's why some hospitals require that you do the testing at their site. That's why it gets to be kind of expensive. Because not just any lab can do it. They have to be specialty labs. The home testing kits, for those of you going into community practice that are explaining these things to parents that want to buy them, those are all urine screens. They're not blood testing, so they're subject to false negatives. And then with all testing, they're subject to what I call false negatives, and that being the person took a drug that we don't screen for. For example, the newer bath salts, THC, homologs, hallucinogenic amphetamines, those aren't tested for. The other problem that you get into it, and it comes into play in the case that we're doing today, is that the unfortunate reality is that with substance abusers, histories are suspect, and then these are histories gained from the abuser themselves or from family members. I can't tell you how many times we've had someone present a case of to the poison center, and it's reported that this patient is a non-drinker, non-drug abuser, and then all of a sudden, 2 days into their hospitalization, they're going into frank withdrawal. When you go back to the family and you say, look, here's all the evidence that we have that this person might be abusing a substance or might be abusing alcohol because they're having this and this and this effect, then you usually find out, well, yeah, they do drink, and you find out later. So their histories are suspect without testing. One of the most notorious examples of that are when you're looking at studies of outcomes in children born to women that abuse drugs during pregnancy. There is a high correlation of failure to report drug and alcohol use during pregnancy. So when you do a survey and you ask a pregnant mother whether she used alcohol or drug during pregnancy, and then you test the child, you'll usually find out that there's a high degree of false reporting by the pregnant mothers. So what we have to do in children is we test what's called meconium. So the first bowel movements that an infant has after it's born, you know, what infants do in the womb is they swallow their amniotic fluid. So if you test the first bowel movements that are produced when a child is born, you can do drug testing on that, and that will tell you if they've ever been exposed to drugs or alcohol during pregnancy. And when you compare the results from meconium to what the mother says was used during pregnancy, there's usually significant differences. So any journal article that you're reading where they're talking about looking at effects of drug and alcohol on infants born to mothers with a history of drug abuse, if they didn't do meconium testing to determine whether abused or not, then that paper is highly suspect for that reason. Any more questions on drug testing, drug screening for drugs of abuse? Just want to, so for class today, you were assigned the case, and you were assigned the chapter from Cecil's textbook of medicine. I think that I assigned this because the chapter 36, I think, really does a horrible job of talking about what are the medical consequences of alcoholism. And of all the review articles I've read and textbooks I've looked at, I think this chapter did the best job of in one place summarizing the medical consequences of chronic alcohol use. Now, one thing I just want to caution you when you're looking at the information and when you're evaluating and you're getting ready for the exam, don't just look at Table 17.2. I like Table 17.2, and it has a nice summary of the medical complications of alcoholism, but it doesn't include all of the information that's found within the paragraph by organ system. So just make sure that you read the text in addition to looking at the table. Okay, because if you just go by the table, you might miss something. Okay. For example, a lot of the issues related to nutritional deficiencies don't appear in the table, but they do in the text. I think one of the only thing that I saw in this chapter that they didn't include that we're getting more and more information about when it comes to medical complications of alcoholism is the alcoholism. And I typed key things out in addition to saying them just in case some people have trouble with their volume on their Wimba, is the association of alcoholism with immune system dysfunction. So we're finding out that this is probably why we're seeing an increased risk of cancers in this population, explains why they're more susceptible to pneumonia and other types of infection than other people in the population. So we're really finding out at a more specific level what alcohol does with the immune system and impairing the body's ability to mount an immune response or impairing the body's ability to separate out a foreign substance that is going to create an antibody to or a natural substance in the body that it shouldn't develop an immune response to. So as anyone looking at the information on the chronic medical effects of alcohol, was there anything in the article that anyone would like me to review or clarify on that, or things they thought were confusing in the information that I could help you with? If anyone is typing while they're doing that, I'll just let you know that the time course of alcohol withdrawal in this chapter is a really good representation because it really shows graphically that these occur over a fairly wide period. So when you look at one information to another, the time to onset of any one of these symptoms is going to be different from text. But I think this chapter just kind of gives you the overall range of when these effects will occur. So I think it makes that information a lot clearer. Again, with any drug that you find, whether it's alcohol, opiates, or any of our drugs of abuse, a common question that I get or you'll get as a pharmacist is how long does someone have to take a drug before they become dependent on it? And the answer is there really is no cut and dried answer. So it really depends on amount and frequency and duration. Kind of a combination of how frequency, and how long. Okay, so someone ingesting a glass of wine with dinner every night is unlikely to develop dependence. Okay, someone who binge drinks once a week is probably unlikely to develop dependence, physical dependence. Okay, someone taking a hydrocodone combination tablet for pain, who takes one tablet at bedtime every night because that's when their pain is worse, is unlikely to develop a physical dependence on it. Someone who takes it 2 or 3 tablets a day every day for 3 days post-surgery is unlikely to develop dependence. someone taking it every 3 hours around the clock may develop dependence in a few days, few weeks, depending on what their dose is. So that's why you won't be able to look up and see how long does it take someone to get dependent on a substance, because it all really depends on that combination of amount, frequency, and duration. I think the other thing to note in this article was that it was at the very end of the chapter, it was talking about the CAGE questionnaire and about how you diagnose alcoholism in patients. Now, as a pharmacist, I don't want you to memorize that table, because as a pharmacist, you're not going to be the one screening patients for alcohol or substance abuse. That's done in other venues. But it's important to you as a pharmacist to know that these tools and algorithms exist, because you're going to read about them frequently. When you read any article on a substance abuse related issue, you're going to hear in the methods section about how they use the CAGE questionnaire to determine abuse. They use the X questionnaire to determine abuse. Or if you're reading any epidemiological profile, they'll say as dependence or abuse as defined by their answers to the following questions. So what you as pharmacists need to appreciate is that these tools exist, that none of these tools have been validated in an IEEE. So different people have different opinions on which tool is the best tool to use in a specific population. So it's not, and you just need to appreciate that these tools exist, that it's not an exact science, and that each of these tools has their positives and negatives. And you need to appreciate that, so that, again, when you're looking at a journal article and reading what you think the results of that journal article mean and whether they're valid, you take into consideration what test was used. And to do that, it means you just have to know you have to go look up what that test is, look at the questions, and see if you think that questionnaire is good. But again, most of these go beyond just asking them, do you use drugs, do you use alcohol? Because usually the first thing you get out of their mouth is no, don't have a problem with it. That self-denial, that divorcing themselves from reality is one of the key functions of someone who's addicted to a substance. So just point blank asking them what their abuse history is and what their whether they think they're dependent or addicted on a substance isn't going to do it, because usually they just have a lack of insight into what's going on, and often the family members do as well. So let's start going through the case, and I think as we go through the case, it'll give us a chance to bring up issues and make sure that everybody understands the material and bring up any questions people may have. So what I'm going to do is I'm going to start going through the case, and just so that these people can be getting ready and know that they're up, the next two people on the call down list are going to be Candace and Kelsey. So I'm just going to give you a heads up that you're going to be up first and second, so that you can be ready when I ask the question. So again, this was a question on case 74, which was alcohol withdrawal. And in this particular case, we're going to start off with 1B, which was what information, signs, symptoms, or laboratory values indicate that this patient is experiencing alcohol withdrawal. Okay, Okay, so I like this case because it asks you to separate out which of the symptoms are associated with withdrawal and which of the symptoms are associated with dependence. So, what did you come up with for 1B? And perhaps okay, so the tremors, tachycardia, hypertension, yes. Now, he has a problem. Did anybody, and this is not on the assigned list, so it's just to fill in the blanks. Does anybody know what's going to be the problem with looking at hypertension as a monitoring parameter for withdrawal in this patient? Exactly. So this is a classic drug disease interaction. And one of the things I really like about my job at the Poison Centers, we spend a lot of that time doing that. We've got a history and we've got an overdose and the effects overlap, and we have to kind of tease out what's what. So we know that he has a pre-existing history of hypertension, and because we don't know what his compliance is with his medication, we don't know what his baseline is. So we don't know if he's well controlled, so his baseline is in the hypotensive range, so that this hypertension is a true indicator of withdrawal, or whether he's not compliant. Because what do you think somebody who's an alcoholic, what do you think their compliance with daily medication is, good or bad? Anyone have a guess? Probably not. And that becomes a real complication of the substance abuse population. Not only do many of these people have concomitant mental health disorders, all right? So they have depression or anxiety or schizophrenia or bipolar disorder. So not only are psychiatric conditions a common comorbid problem in the substance abusing population, but they have medical conditions just like everybody else. They might be smoking, male, overweight, diabetes. They have risk factors for a lot of other illnesses. But because of their substance abuse issues, because of wanting to avoid the medical system, because they don't want people ragging them about their drinking or their drug use, they'll go. Or if they've gone, they're not compliant. So they come in with a lot of serious complications and chronic complications of hypertension and diabetes and other issues because they don't take care of themselves. And if they're using IV drugs, they can come in with hepatitis B, hepatitis C. So these people can be a real dilemma in teasing out what's related to the current condition and what was pre-existing. So, in the end, and again, I'm going to ask this, and it's off the grid of the case. So, no penalty for wrong answer here. Can anybody can tell me, so what in its history would Miss think? So we've got two other symptoms associated with withdrawal. We've got the tremors, we have the tachycardia that are consistent. What in this history, what information was provided in the case that make us think that odds are great that this hypertension is part of the withdrawal? So what part of the history of present illness do we have? No, I'm going to choose you. Candace, I'm going to do for one of the questions I assigned. This was not one of the questions with the case. So, but if you want to answer it, that's great, and I'll count it for your question. But free-for-all questions to the class. What in his history would make you think he's at risk for withdrawal? Exactly. So he's got this history of 14 to 18 alcohol beverages for 25 years. So I think that follows what we talked about above with amount, frequency, and duration. That's a lot. It would be hard to drink 14 to 18 in one sitting, so it's probably throughout the day, and we have 25 years. So odds are it's history of excessive alcohol use, and then he hasn't had a drink in 48 hours. He'd have to be a miracle if he wasn't in withdrawal. So we've got a history consistent with withdrawal. We've got tremors and tachycardia consistent with withdrawal. So odds are a lot of this hypertension is withdrawal as well. Now, again, this case is unusual in that we had that drinking history. Usually in real life, we have no idea. They come in and say, oh, I only drink a couple of beers every day, or I only drink a couple of alcoholic drinks a day. It is rare that they come in and are this upfront about what they've taken. So usually it's up to you to be looking at their medical conditions that make you think they have a problem with alcohol. So that puts you on guard to the fact that they may go into withdrawal or they may be in withdrawal. So that gets us to question 1C. And Candace, since this was an assigned question, now I'm going to ask you specifically. So what signs, symptoms, and history are consistent with dependence in this patient? Okay, so those are 2. Increased billing, good. Exactly. Okay. And then when you're done, just type in done. Okay, done. So the hypokalemia could be or couldn't be. It's hard to tell in this symptom, but likely it is. All right. So those are a good chunk of the clinical symptoms. The next 2 up are so Caitlin, Candace got us off on a good start. Can you tell us what else in him is consistent in his physical exam, his signs or his symptoms that are consistent with alcohol dependence? Sorry, Kelsey. Okay, Okay, so the GGT elevation, that's really consistent with chronic alcohol use. The sweating probably goes along with the withdrawal, and the increased heart rate goes along with withdrawal. But the GGT elevation is definitely assistant of chronic alcohol dependence. Can you give me one more, Caitlin? Okay. Well, actually, is his INR is elevated. So remember, and if you guys are confused on this, make sure you go back and read that liver function test article that I provided you in the toxicology module. So the normal INR equals 1. Okay, a therapeutic INR, if on warfarin, when you purposely want to anticoagulate you, depending on the disease state, is 2 or 3. So anything above 1 means that your body isn't creating enough of the coagulation factors. Okay, so normal is 1, and his is 1.3, and he's not on warfarin. So that would make his INR slightly elevated. Your coagulation factors are some of the last factors to be affected when your liver system is disrupted. So your AST, ALT burst first, right? As you get necrosis of your liver, of the cells in your liver, they split open and release the AST and ALT. So that comes first. Later stages, you start affecting your liver's ability to generate coagulation factors, and your INR increases. Kelsey, so we've got the GGT, AST, ALT, Billy, the INR, the potassium. What else in him is related to a clue that he has an issue with chronic alcohol use? Hepatomegaly, exactly. So that'd be something that you can see or feel that goes along with his elevated liver enzymes. Anything else? Can you give me 2 or 3 more? Low albumin, exactly. So low albumin indicates malnutrition, which, as you read in the Cecil article, is a problem with alcoholism. Increased B1, that would not be specific for alcoholism. When the B1 starts to go up, that usually just indicates dehydration. Okay. So it's non-specific, and it occurs with a lot of things. People coming in with the flu, people who haven't eaten for a while. So not so much that one. But that hepatomegaly and low albumin were right on target. So Amy Toller, he was the other couple of things. There are things left in his physical exam findings specifically that are. Okay, so he's had a previous seizure with no history of a seizure disorder. So that may make you think that he had alcohol withdrawal seizures in the past, which would be consistent with alcohol dependence. So that's really good. Okay. So great, Kelsey. So Amy, can you add anything on to that? Okay. So the PT elevated goes along with the INR elevated. So we already said the GGT. So we mentioned the ALT being elevated, but you point out a really good point, and that is looking at the ratio. So again, if you remember back to the liver function test article you read in the therapeutics module, ALT is a lot more sensitive to thiamine depletion than the production of AST. With alcohol, one of the problems with alcoholics are chronic nutritional deficiencies. They don't produce a lot of thiamine, so they don't produce a lot of ALT. So when the cells start in the liver start bursting over and releasing their contents, they have less ALT at baseline to release. So you usually get that 2-to-1 ratio. So right, that 2 higher is suggested of liver disease from alcohol. So aside from labs, I think we've got the labs. Anything else in his history? For example, we have so the icteric sclera goes along with the increased bilirubin. Okay, the amount of drinks per day. So we'd already picked that up with his history. The positive hepatomegaly, which goes along with his liver function test. Everyone, take a look at his weight and his height. You calculate the BMI for him, it's 19.6. So he's underweight, which goes along with being malnourished. Okay? So he's an undernourished appearing male, and that is backed up by his low BMI. He's got increased liver function test, increased INR, which goes along with hepatomegaly. He's got his increased bili, which along with his icteric sclera. Right? He's got a history of hypertension for 10 years, supposedly on meds. We know it's not well controlled because he's presenting with mild AV nicking in his that they can see when they do the fundoscopic exam in his eyes. So he's got evidence of chronic hypertension. So he's not being treated. And what we can't prove the best is GERD for 4 years. You know, alcohol causes an alcoholic gastritis. So even though it's listed as being GERD, you got to wonder whether that is alcoholic gastritis. So again, a lot of these people come in without this nice history that was presented to you here. And so it's up to you almost to be detectives and to look at their review of symptoms, look at their labs, and see all of these things that you guys have pointed out that are consistent with alcohol use. Okay. Now, if alcohol was negative, which is consistent with the fact that he hasn't had anything to drink, and his other symptoms go along with withdrawal. So just based on that, even if you didn't have a history of present illness here, you could guess this is a chronic alcoholic who is now in alcohol withdrawal. One of the things that we use as a really good indicator of alcohol dependence or alcohol abuse is, if you remember back to the toxicology lab, how we talked about we get an alcohol level on any intentional overdose patient that comes in. So if I get a person and they report to me that she is awake and alert, and their alcohol level is over 200, that tells me they're alcohol dependent. Because legally intoxicated, as you guys mentioned the other day, is 80. People who don't drink, people who rarely drink, that would cause them to be symptomatic. It would probably put most of you at a state where you would notice that you were intoxicated. But people with you at a level approaching 200 would be very obviously symptomatic from alcohol. So if they're presenting awake, alert, and oriented, and the only way that we know that they've taken alcohol is to have done a level and find out that their level's over 200, that's usually a clue that they have dependence. So when they come in and they have a high alcohol level and they're not very symptomatic, we put them on high watch during the hospital setting for alcohol withdrawal. Now, the complicating factor, and usually cases aren't as clean as this either because of the issues of polysubstance abuse. Especially when we start to get into people who abuse medications, they often abuse more than one medication or medication on top of alcohol. And so you've got symptoms of not just one drug, but of multiple drugs. So this is a really good case to look at, but keep in mind it's often not this easy because they usually are taking other drugs as well. Okay, so it's 5 till 3. So I know all of you need a break, clear your mind, walk around for a little bit. So we will take a break until 5 after 3. And when we come back, we'll finish the case. We'll move on to summarize some additional information on alcoholism and alcohol withdrawal. So take 10, and we'll be back at 5 after 3. All right. Time flies. All right. So, as a heads up, the next couple of people I'm going to call on are going to be um, okay. So, as a heads up, those are the three that are next. All right. So again, he presented raw. So he's sweating, shaking, possibly got a seizure an hour ago. He's confused. He's hypertensive. He's tachycardic. Looks like he's a little tachypnic as well. Diaphoretic, and his alcohol level is 0. So looks like he's had an alcohol withdrawal seizure and he's in frank alcohol. He also has a lot of things in his history verified by his review of systems in his labs that are consistent with the fact that he's also alcohol dependent. So on his problem list, problem number 1 would be alcohol withdrawal. That's the most immediate threat to life. Okay, so that's going to be problem 1. And problem number 2 is going to be alcohol dependence. So we're going to have to cover problem 1, and then we take care of problem 2. Not to say that if he doesn't have something, a medical complication of dependence, we're not going to address that immediately if that's also a threat to life. But overall, I think in him, withdrawal would be first and dependence would be second. And then third would be a discharge, thinking out what we're going to do about his persistent unmanaged hypertension. All right, so with that, the next question is, and this one would be for Justin, what are the goals of pharmacotherapy in this case? Okay, so let me phrase that a little more generally. So, which one, bullet one or bullet two? You're going to lump all of your thoughts together. He chose curtain one. That's good. Our ultimate goal, we have to pick what is our ultimate goal, and our ultimate goal is going to be to prevent life-threatening symptoms. Okay? So, the life-threatening symptoms, seizures can be life-threatening, hypertension can be life-threatening, they can go into status, they can develop the delirium tremens, which have a fairly high mortality rate. And they talk about this in the textbook chapter that I gave you, and these are summarized here. Mortality can be up to 15%. All right, he's over 45. He's got other concomitant medical illnesses, so he's at high risk. When they usually die from a myocardial infarction, respiratory arrest, sepsis, especially if they've got symptoms of chronic alcohol use that like he does, they're at especially high risk. So if you add unrestrained hypertension on top of esophageal varices, you had a high risk for GI bleed here. So he's got a lot of risk factors here. So again, as Justin correctly noted, preventing of life-threatening symptoms is going to be our key goal. Because that is our problem list number one, and that's what will kill him first. We'll deal with the rest of the issues later. Okay, so the next question is, so what pharmacotherapeutic alternatives, if there's one, is available for the treatment of alcohol withdrawal? And that will be for Kara. Benzos, exactly. So it goes up to what we talked about on Monday, and that is our treatment options. So, Kara, when you said benzos, which is exactly correct, does that match door number one, bullet one, or door number two, bullet two? Exactly. So using benzodiazepines is an example of using a cross-tolerant drug and tapering it. So we're not going to give them alcohol. Now, there are some hospitals out there that will give these patients alcohol. See it happen. JCAHO, the Joint Commission, hates it. It's not considered good medical care. Think of all the drug interactions with alcohol. You're contributing to medical conditions that are already made worse because of alcohol. Occasionally when I'll see it are people coming in for elective surgery or elective procedures, They know these people use alcohol. They don't want to mess with this patient going into withdrawal. They're a short-term hospital stay person in for an elective procedure or a short-term care. So they'll just give them alcohol while they're in the hospital, a couple drinks a day to prevent them from going into withdrawal. Not considered ultimate best practice, but I've seen it done. So what you want to do is you're going to use something that's also going to attach to the receptor affected by alcohol, that GABA receptor, and in this case, benzodiazepines. So benzodiazepines will help prevent their life-threatening symptoms as well. Because benzodiazepines treat seizures, all right, because it's a cross-tolerant drug. All of the clinical effects of withdrawal that we're seeing, his sweating, his confusion, his tachycardia, his hypertension, should respond to the benzodiazepines, right? They have a wide margin of safety. Phenobarbital works on GABA as well, but that's got a very small margin of safety, as we talked about in the toxicology module. So we're going to want to use benzodiazepines. We're not going to use phenytoin, right? It doesn't work on GABA, so it makes no sense to use it, and it's not going to work. Now, what was good about his care in the past is he has a history of an alcohol. If he had a history, when he leaves the hospital, what we're going to want to make sure that we do is not send them home on benzodiazepines or not send them home on seizure meds. Okay? Seizures seen in alcohol withdrawal or withdrawal, it's not a long-term seizure condition. So these people don't need to be on chronic benzodiazepines. And one of the most effective things you can do as a pharmacist is make sure that people who had a seizure during withdrawal are not sent home on chronic anti-seizure meds. It happens all the time. If you see a medication profile of an alcoholic on phenytoin, no one can remember why he was ever on it, doesn't report, his family doesn't report, nothing in the medical history about a seizure disorder from a prior head trauma or anything else, odds are, if you look way back, you'll find that it was given during withdrawal and then never removed. Okay, so just not a good idea. So we'll give benzos to treat with withdrawal, and then when he's done, he's ready for discharge, we make sure that they're taken out. So, good. So the next question is, I just want to mention a couple of things about the use of benzodiazepines for the treatment of alcohol withdrawal to clarify some of the information that's in the text. And that is that any benzodiazepine will do. If you look at the literature, there is no evidence that any one benzodiazepine is better than any other. Usually they like to use one with a fairly large half-life. If you use one with a short half-life, you're going to have to give multiple doses. And what you get is symptoms, no symptoms, symptoms, no symptoms, symptoms, no symptoms. It's pretty erratic. So usually they'll try one with a longer half-life, like chloride epoxide, like Valium, like lorazepam, as opposed to the shorter-acting ones. There's the advantage of lorazepam in that it can be given IV. Okay, chloride epoxide comes in an injection, but it has to be given IM. Lorazepam can be given PO or IV, so it's pretty versatile. Okay, and it can be given IM if necessary. So any benzodiazepine will do. It's really up to physician preference. So the next question this one asked was, what electrolyte imbalances need to be corrected in this patient and what vitamin deficiencies should be corrected? And that one is going to go to Stephanie. And while she's typing in the answer, I'll address the question someone asked about what if they're metabolized by the liver. So you bring up a good point, and I failed to mention that, so thank you for catching me on that one. If you have someone that has end-stage, pretty significant liver dysfunction, like he has, as evidenced by its high GGT and his INR being elevated and hepatomegaly, icteric sclera, hemolysis, you'll want to pick one that is not metabolized by the liver to a large extent. So you'd want to stay away in this patient from chloridase epoxide and away from diazepam, and lorazepam would be a better option in him. So exactly. If someone is, not all alcoholics have liver disease. So if there's and impairment of drug metabolism is one of the last liver functions to go. So if they don't have, they're a chronic alcohol user with no liver problems at the time, you can use whichever you want. Probably you're right, in him we should pick one that's not extensively metabolized by the liver. So great point. I'm glad you brought that up. Exactly, Stephanie. So thiamine is one of the vitamins that is especially problematic in these patients. Remember, it's the reason that we have to give glucose before we give naloxone in these patients, because if you remember, thiamine is essential for glucose metabolism. And if you give them glucose to someone who's thiamine depleted, you instantly deplete their thiamine, and they can get Wernicke's encephalopathy. So they get depleted of electrolytes, they get depleted of vitamins, one, because of their poor nutritional status, but there's also some evidence that they don't absorb some of their vitamins as well, either when you have someone with chronic alcoholism. So there's some evidence that they might not absorb their fat-soluble vitamins as well. In addition, they're nutritionally depleted and they don't absorb their vitamins as well. So standard thing that you'll see alcoholics get is a IV solution with a multivitamin injection added. The multivitamin injection is yellow in color because of the B vitamins. Okay, so when we have little kids that get to their gummy vitamins and eat the whole bottle, we always warn the mother that their urine is going to look yellow or orange for a few days from all those B vitamins. The multivitamin injection that you see in hospitals is yellow. And so what you'll get and what you'll hear in the hospital system is you'll hear things like a yellow bag, banana bag. So you'll see they started them on a yellow bag because it's a soft drink, or a banana bag because it's yellow. I can tell you that Joint Commission can't stand those terms. They're not correct. They hate abbreviations. It doesn't specify how much multivitamin, how frequently, and what fluid. So Joint Commission hates those being used. Despite that, you will see some physicians use them. What they're referring to is giving these patients a multivitamin injection. So when patients come in the emergency room, if they think that they have a history of alcoholism, standard procedure is they'll put them on a multivitamin solution. Okay? So that's probably what would be done in this person, in addition to giving him some potassium and maybe some other electrolytes that he's missing. As you know, with potassium, oral magnesium is as quick as IV, and it's safer. You don't have to worry about extravasation. You get potassium accidentally out of the vein and you get necrosis. Oral is cheaper, safer, and it's just as good. So if they're not having a lot of vomiting and they're cooperative, get them to take some oral potassium supplements. If he's already going to have an IV bag that contains some magnesium, some phosphorus, some other things, the decision maybe just since you're having IV anyway, you can go ahead and add the potassium to the IV fluids, which is probably what would happen in this case. But if he's just potassium depleted, the oral would be just as good. Okay, sorry about that. Oral is 4K. He also has low magnesium, which is 1.6. So he needs K plus magnesium. Plus, he knows all three, so they'll probably give him some sodium chloride. You'd put it in some normal saline, add chloride to it. He might get some intravenous magnesium, and since they're having to put an IV in and give him chloride and magnesium at the same time, they'll probably just go ahead and add the K to the IV because he's got one anyway. But let's say he was just low on K, it's always safer to give it orally. Safer, less expensive to give the K orally. Oh, in regards to safety, I'm sorry. Magnesium is pretty safe if you give it IV. It's the potassium. So usually one of the drug reviews that hospitals do is giving people their potassium orally if at all possible. Sorry if I confused you guys. Just feel free to call me out on it. I appreciate it. I'd rather be corrected online than tell you guys I'm wrong. So again, these people will standardly get IV solutions. He obviously needs it. His albumin is low. He's undernourished. His BMI also proves that he's undernourished as well. So the question then becomes, how are we going to give the benzodiazepines? So if you haven't already done so, this is why I wanted you to look at 36.5 in the chapter. So this is the Clinical Institute Withdrawal Assessment for Alcohol. So the purpose of this is some of the symptoms of alcohol withdrawal can be subjective. If they're vomiting, that's pretty objective. You see them vomit. If there is tremors or sweating or vital sign changes, you can see that. But anxiety, nausea, feeling agitated, visual disturbances, orientation, that can be subjective, and that can be purposely altered by the patient if they like getting the benzodiazepines. So these assessment scales, the purpose is to try to make management of alcohol withdrawal there as objective as possible. So what it requires is that you go through these questions and you give them a score. So you noticed, or if you don't, you can look at it after class, that there's a scoring system. So you rate them, you score them, and based on their score, it places them at a severity scale for alcohol withdrawal. And then you base the dose of benzodiazepines based on their severity scale. So this is an example of using the CIWA scale is an example of symptom-based treatment. Okay, and scale has been validated, and they've shown that symptom-based treatment uses less benzodiazepines. I can spell here. And it's shorter, so it's been validated. They show it uses less benzodiazepines overall, and is shorter than the alternative, which is scheduled doses. Okay, so scheduled doses are where you come in and you say, yep, he's in withdrawal, so we're going to give him X milligrams of X benzo every 4 hours for 2 days, and then every 6 hours for 2 days, and then once a day for 1 day, and you kind of taper him off. Right? So if it's better for the patient, it uses a validated scale, it uses less benzodiazepines and shorter, why doesn't everybody use the CIWA scale? And it's because it's perceived to be time-consuming by nurses. So the nurses have to go ask the questions and document it and give the dose. But if you do scheduled doses, it's just easier for the nurses to give the dose on a scheduled time period. So unfortunately, even though evidence-based medicine says symptom-based management is better You have less risk of overdosing, giving the patient too much benzodiazepine so they're over-sedated. That's better overall. Unfortunately, you still have a lot of people using scheduled benzodiazepines just because they perceive it as being easier. But whatever other studies are looking at are shortened examples of this complete CIWA scale, trying to find a balance between nursing time and sensitivity and specificity of the adult patient. But ideally, the CIWA scale will be used, but unfortunately, you may not be seeing it used as much as it should be, and as pharmacists, you can be advocates for that. So, so if we're going to give the benzodiazepines, then we need to look at, I'm using that term overdosing a little bit looser. You've given them too much. You've given them more than they need, so they get over-sedated. And when they're over-sedated, you're going to increase hospital length and stay. And you're going to decrease your ability to talk to them and see how oriented they are and really monitor whether their symptoms of withdrawal are going away. So for monitoring in him, he came in with diaphoresis, sweating, tremors, hypertension, tachycardic, maybe some tachypnea. So what you're going to do is you're going to do the CIA scale, you're going to rate him, you're going to give him his benzodiazepine doses, you're going to come back, rate him again, and you're going to increase the dose until you see the effect that you want, which you can objectively validate by your score as it goes down. Okay, so your goal is going to be to reverse the symptoms that he's having, right? And to prevent him having delirium tremens and to prevent him from going into further seizures. So those are going to be all of your monitoring parameters. Right now, you could also monitor his potassium, you can monitor his magnesium to see if those get up to normal values. But that's probably the extent of what you're going to be able to monitor for. Now, the reason that it was important in this case to think about what our first problem was, which was ethanol withdrawal, and develop a plan for that and monitor for that, is because are we going to be able to, at this stage, especially why he's in withdrawal, do anything about the medical symptoms of dependence? And the answer is not really. We can't fix overall undernourishment and being underweight in 2 days. We can't correct his liver abnormalities in 2 days. We can't correct the long-term consequences of hypertension as endoscopic evidence that he's got chronic hypertension in just a couple of days. So the best that we can do is to see if prior to discharge we can get him to go into okay, so medically, we can start treatment for withdrawal. We can monitor the benzodiazepine use, make sure his symptoms of withdrawal are being measured, that he doesn't develop the life-threatening effects. So the hospitalization or therapeutic drug monitoring is going to be all about managing the withdrawal. Okay, and then we're not going to really, in this first hospital setting, do anything to reverse his chronic alcohol effects. That's not going to happen in a couple of days. The best thing we can do is stop those effects from progressing by stopping any further alcohol use. Right now, it's an addiction. Addiction, the whole definition of addiction is despite the fact that they know it's affecting their job, their relationships, their life, their health, they can't stop. That's what an addiction is. So despite the fact they came in really sick, was hospitalized, could have died, that might not be enough to get them to stop drinking. So that's where our substance abuse programs, our alcohol abuse programs come in. And so hopefully during his admission, he'd get set up with social services and get him set up with an alcohol addiction treatment program to help maintain abstinence. Unfortunately, as we talked about maintaining abstinence on Monday, that's very hard to do. We are getting better insight into the pathophysiology of dependence and addiction for drugs and alcohol, all right, which is going to help us develop better drugs. But right now, we don't have really drugs. And again, it's slow going because, as we talked about on Monday, it's really difficult to do these studies. Okay. It's difficult, so it takes time, and it's not going to happen anywhere in the near future. Again, I'm in this class. I'm not. I'm not going to stress the drugs used for alcohol abstinence. So even though I'm not going to test you on them, now make sure you've read the parts of the chapter that I assigned, because that will give you a real good overview. Because I think as a graduate pharmacist, if someone asked you what naltrexone was for, what acamprosate was for, you could say alcohol dependence. I think that the overall point that you need to remember is that we don't have a perfect drug yet. And don't just read what the drug representatives are saying about the products, because ideally the goal is, in my opinion, is zero alcohol use. To me, it's my opinion. I don't see the value of a drug that just decreases how much you drink. If you've got a patient like this who's addicted and dependent and has is only going to be medically managed by completely eliminating alcohol, I don't see how just decreasing the number of drinks that he takes a day is going to get very far. Some people may agree with me. That's just my opinion. So I tend not to be highly favorable of the drugs that just decrease use instead of decreasing your chance of staying off alcohol permanently. But again, they're still searching for drugs that may do that. Okay. So getting them through the withdrawal period can be easy. Keeping them in abstinence can be a little bit different. And again, it's hard because we've got to go back and look at their risk factors, the reasons they started using those substances to begin with, all right? And just adding a drug like acamprosate or naltrexone isn't going to do it unless you've really gone back to what we talked about on Monday. Why were they using substances to begin with? And if they were self-treating with depression or anxiety or ADHD or what all with alcohol, if you don't fix that, this person's never going to stay off of alcohol use. Okay, so you really have to take the time with these individuals to see what was their reason for using the substances and address that. Okay? And then give them the support to get the cravings for alcohol that they're going to have for a very long time to keep them abstinent on those. And there's discussion into the psychology of how they do that and how AA meetings work. I think it's kind of off topic for this class and as pharmacists, because other healthcare workers do that, but we do need to know that they exist. And again, we do have the addiction risk factors. But again, addiction risk factors or not, doesn't mean that these are an excuse not to maintain abstinence, and that's what gets dealt with in the 12-step programs and the other alcohol abstinence programs that are out there. Okay, so what I want to finish up with in the last couple of minutes of class is taking this back to what we talked about Monday, and because I told you I would keep tying this in. So in going back to the ASC statement, so what is the pharmacist's role in all of this? So I'm going to throw out a couple of roles where I think pharmacists have a role in alcoholism and alcohol substance abuse issues. I've given you some examples of where we probably have a role, and that is in diagnosing alcoholism, because we're not in a position to be administering CAGE questionnaires or alcohol questionnaires to people. We're not in a position to be running an AA meeting or to getting them in the right alcohol treatment program for them. We're not in a position to be diagnosing the chronic medical complications of alcoholism and ordering the test to do those. But here is where I feel that pharmacists have a role in this problem. One is to know about it so that we're in a healthcare professional role. We're in a role to help make sure that people that we are working with are doing their job safely so that they don't put patients at risk. So you need to, as a pharmacist, be able to identify alcoholism for fellow pharmacists that you're working with and your pharmacy technicians that you're working with and the people that you work with on a daily basis. Because if you don't, and you don't recognize it, and that person is allowed to keep working, someone is going to get injured. One of your customers in your store is going to get hurt. And unfortunately, we've got a lot of dentists, pharmacists, nurses, physicians that are alcohol dependent. And again, part of the addiction is a lack of self-awareness, a lack of insight, or denial. So part of the pharmacist's role generally to protect the public is to make sure you can identify it if someone that a pharmacist that you're working with or a pharmacy technician that you're working with is having a problem with alcohol dependence. So I think that's number one. I think another role for pharmacists for health safety is to Now, there was a whole table in the chapter on drug interactions with drug and abuse, and I X'd that out. I told you not to focus on that for this class. It's just a 6-hour class. That's just way too much information to test you on or expect you to go through. You've picked that up in all of your classes. You've been talking in all of your other therapeutics classes about drug interactions with alcohol. So if you have that regular customer or that person that you're managing in a hospital or in a community setting or in your community pharmacy, and you know they have problems with alcohol, right? There are certain drugs that they probably would be a risk for them. If their alcoholism isn't controlled, those patients shouldn't have a chronic prescription for benzodiazepine or phenobarbital, something that when mixed with alcohol could cause respiratory depression and death. So, and you're in a position to identify that and maybe have a conversation with their physician. If you know, because you see the signs because they're in your store all the time, that they have an alcohol problem or their family members confided in you that they do, to identify that. I think another thing, especially if you're not a hospital pharmacy setting, is identification of withdrawal risk. Now, at the Poison Center, for example, we don't provide management recommendations for abstinence. Okay, our job, we get consulted about the poisoning, but if in the course of managing that poisoning, we see symptoms that are consistent with withdrawal, or we get hints from the history that this patient is at risk for withdrawal, our role is to point that out with them, to them, and recommend that they consider benzodiazepines for the management of alcohol. So as a pharmacist, if you're in a hospital setting and you're looking at a chart or you're part of the team and you see that they have a lot of symptoms consistent with alcohol withdrawal, alcohol is a drug. So part of your role as a pharmacist, if the team isn't discussing it, would be to say something like, hey, I'm noticing that they have this, this, and this. Do you think this, I'm just wondering if this patient isn't possibly going through alcohol withdrawal. Because I noticed in this history, I see this, this, and this. We've got this, this, and this symptom. So just putting that on the table. Alcohol is a drug, and pointing out adverse effects that people are having the drug is part of what a pharmacist does. So that would be a role for a pharmacist in the hospital setting. The ASP position statement talks a lot about appropriate education of the public. So pharmacists can help people, the lay public, understand about alcohol kinetics. Helping them appreciate why you have that rule about alcohol per hour. Because remember, it's all about plasma concentration equals amount divided by volume of distribution, and how much alcohol undergoes saturation kinetics at higher levels. So once you get into that legally intoxicated range, alcohol undergoes saturation kinetics. With just a drink or two, it goes under regular first order kinetics. So that's where you get that drink per hour rule. It's because if you look at their predicted alcohol level based on one drink and an hour, if you keep to that limit, you're probably not going to get legally intoxicated. But if you're drinking it faster than your body can clear it, you're going to get into that legally intoxicated range. Okay. So you can help them understand why drinking coffee isn't going to speed up the kinetic metabolism of alcohol. Drinking coffee may make them more awake, but you can help them understand why that isn't going to fix anything. Because there's that, still a lot of people believe that, and you can help them understand that. You can help them understand why once someone's legally intoxicated, it takes longer for them to get rid of the alcohol than it does if they just had a drink or two because of saturation kinetics. So again, using lay public terms that you can that they can understand, you can help educate the public as far as safe drinking practices. So when you go to high school groups, you go to other chances to do health and safety fairs, that's a role that a pharmacist can play. I think pharmacists have a role in educating family members about again, the patient themselves often lacks insight, but the family can sometimes help be convinced that their family member has a problem, and helping educate the family member are just on the social consequences of their family members drinking, effects on their job and their family, but on the medical risks, and helping the family members understand the medical risks of the patient, which might help that family member encourage their family member to get them into treatment. So that's a possibility. Okay. Another obvious thing to think about, obviously, is for those of you in a retail setting, if intoxicated, you sell not alcohol. So again, if someone comes into your store and your store sells liquor, do you sell an intoxicated person liquor? If you do, you need to make sure that they're not driving. In West Virginia, we would have what's called the Dram Shop Act, which basically says if you overserve an individual and they get in the car and get in an accident, you can be held liable. The person who drove drunk can be held liable, but if they can show that you provided the alcohol that they got drunk with, you can be liable. So technically, if they come into your store intoxicating stuff and alcohol and they get in their car and drive and get in an accident, you could be liable for that. So again, just common sense about, if someone's obviously showing signs of intoxication, something to consider. So again, even in something like alcoholism, I think pharmacists have multiple roles, and what everyone think about is where you work, what little piece can you play to help protect the health and safety of the person drinking and the person that might be affected by their drinking. Even if in this particular topic, we don't have an overwhelming role in preventing addiction in the first place or managing addiction once it occurs. But again, I think the overall message is, this is such a big, substance abuse is such a big issue. No one can do everything, but we can all in our fields do our little part. And all of those little parts together make a difference. Okay, now just as a reminder, the multiple choice questions are due Monday at 10, so make sure you've submitted those. Monday, you need to meet in the classroom because we're going to do MDTP the first hour. And then after the 10-minute break, we're going to come back and do WIMBA. Okay. So just some reminders on that. Make sure you've looked at the reading before you come to class on Monday. It'll make everything that we talk about make more sense. And again, like we did today, we'll reinforce the information that we provided on Monday and then show you how that applies to opiates, which is going to be the focus of the conversation for Monday. So about 1 minute till class ends, but I'm happy to stay on WIMBA for another few minutes. If anyone wants to ask questions, I'll be happy to answer them. And if not, have a great rest of your week, and I'll see you on Monday. All right, looks like it was a few questions, so I'll go ahead and off. So if anyone thinks of anything, they can just email me.